All right, so first we're going to start with a joint play assessment. We're going to be assessing the talocrural joint and the subtalar joint today. Before we get started, the talocrural joint is between the tibia and fibula and the talus. So the tibia and fibula is concave, the talus is convex. To keep in mind with the talus is at a bit of an angle. So when you do the joint glides, they are not purely at within one plane. So the medial part of the talus is a little bit more anterior. So that's going to affect the joint glide that you're doing. So when you do a joint play assessment, you always want to start with traction. So for here, we're going to hold on to the bottom of the foot. You can do this with one hand, but since I have small hands, I like to grab with both. So you're going to grab with both hands around. You're going to weave your hands together like this, and you're going to use your pinky fingers to feel that space. As you're creating that gapping, you have the foot in about 10 degrees of plantar flexion, as that's the open packed position, and you're just pulling towards yourself for that traction force. Then next, you have an anterior glide. So you're going to be underneath the calcaneus, and you're going to be stabilizing with your other hand on the tibia and fibula, making sure that you're not in the way of the talus, coming anteriorly. So you're going to come up like that. So we got that anterior glide, and then we also have a posterior glide. So for the posterior glide, you're going to want to put your hand underneath. And then for here, you're going to use your hand now on the talus to bring the talus posteriorly towards the table. You can have the heel off the table so that way it has room to move. Next, we have the subtalar joint, so that's between the talus and the calcaneus. So in this case, you can do traction of the calcaneus by bringing the calcaneus inferior and posterior in this direction. So in that case, we're holding onto the talus and bringing that calcaneus towards the floor. And then the subtalar joint does ab and adduction and inversion and eversion mainly. If I didn't mention, the talocrural joint is mainly dorsiflexion and plantar flexion. So for that, you can assess the tilt of the calcaneus to get that inversion and eversion. So instead of doing directly medial and lateral, you're getting that radial and ulnar deviation to do a rotational force. So you're stabilizing the talus and rotating to either side. And then you can also do that medial lateral glide to specifically target AB and adduction. So you can switch hands to get it that way, or you can just do a push and a pull. All right, so next we're going to be doing some functional tests. All of these functional tests are related to functional movements that they would do in daily life. So we're going to assess squatting and assess unilateral stance. These can be for pain provocation and also to see any compensations with these functional activities that they might not have told us about in their subjective history. So first we're going to start with a squat. So we're going to have Katie squat down. So she's going to pick up something and then come back. So we're looking to see if her knees bow in, where her feet are placed, if her heels come off the ground, all sorts of different compensations that you could potentially see. You could also see if she goes more flat-footed when she squats down, or if she tends to weight bear on her heels or on her toes, or more laterally or medially. This could also be pain-provoking due to the dorsiflexion as she goes down and loading of the tissues in her feet. Then we're going to do unilateral stance. So I'm going to have Katie face me a little bit, just a little bit, that way they can still see you. And for this one, I'm going to have her hold my hand. Since this is not a balance assessment, we're more concerned about the ankle strategies and what's going on in her lower extremities. So I'm going to have her stand on one leg. We're going to see what happens for a couple seconds, and we're going to switch. We're going to do this 2-3 times just to see what happens when she shifts her weight onto that one leg, where her weight's going. Is she popping a hip out? Is it going through her knees? Where is she putting her weight through her foot? Kind of like for the squatting, just with a different activity. Unilateral stance is really important, especially considering it's a large part of the gait cycle. So, very important to look at. Next, we're going to start moving into some special tests for the lower leg, ankle, foot. So we have the compression test, also known as the squeeze test. So we have our patient in supine, and we're going to be compressing the tibia and the fibula together to see if that compression force creating a distraction force distally at the distal tib hip joint could potentially be some pain provocation. So we'll start at the mid-calf, and then we can work our way up and work our way down, holding that pressure for a couple seconds and then releasing. So the compressive force up high is creating a distraction force down low. This could be aggravating the ligaments in the tibiofibular joint that could potentially be impaired with a high ankle sprain, so like the anterior or posterior tibiofibular ligaments. So, and it could also be positive for ankle syndesmosis pathologies. Next, we have the fibular translation test. So we're going to have our patient's leg internally rotated. So in this case, the table is creating the stabilizing force for the tibia. And then we're going to be doing anterior and posterior glides of the fibula. So I'm also using the heel of my hand to stabilize the tibia to the table. And I'm going to use the heel of my other hand to do a posterior glide of the distal end of the fibula, and then also use my fingers to do an anterior glide as well. So this is a pain provocative test. This could be positive for patients with high ankle sprains, syndesmosis issues, or fibular fractures. So you're looking to see if they have pain with this, or if there's more mobility than normal. And like all of our special tests, you would test bilaterally. We have the anterior drawer at the ankle test. So this test is using an anterior glide of the talus and the calcaneus to provoke the anterior talofibular ligament on the lateral side of the ankle. So we're holding onto the calcaneus, putting our foot on the forearm, and then using our other hand to stabilize the tibia and the fibula to the table. And then you're creating that anterior force. Unlike the joint play assessment, although this looks very similar, you're going to be looking for a gapping near the lateral malleolus, which would indicate that potential sprain of the anterior talofibular ligament. And you're assessing for excessive motion when compared bilaterally. In addition, you're also going to ask for pain provocation if it provokes their symptoms that they had when they came in to the clinic. In addition to this, there is an alternative version of the test where they bend their knee to 90, and then you're going to stabilize their foot on the table. You're holding that talus with your hand, and then you're going to use your other arm to create a posterior force, which in this case looks kind of superior, and you're using your other hand to move the tibia and fibula posteriorly, basically doing the opposite motion, but it's creating the same joint glide. Next, we have the talar tilt. Contrary to its name, you're actually manipulating the calcaneus instead of the talus. So we're targeting the subtalar joint with this test, and specifically pain provocation for the deltoid ligament and the calcaneofibular ligament. So with this test, you're going to stabilize the talus, and then you're going to be creating that rotation, just like earlier for inversion and eversion. So with inversion, you're targeting the calcaneofibular ligament on the outside here, and then for eversion, we're targeting that deltoid ligament medially. and then we would see if they have any pain with either of those motions. Next, we have the Thompson test. This test is assessing the integrity of the Achilles tendon. So if the patient has a potential for an Achilles tendon tear, so you're going to get a good grip on the gastroc and soleus, and you're creating a compressive force to see if the patient plantar flexes. So you're basically manually activating the muscle to create plantar flexion. And if you're not seeing any movement, another way that you can create this movement and make sure that it works is you can put their foot on you and get them into a little bit of passive dorsiflexion. And then when you do that squeeze, see if they kick you. Which Katie is kicking me. So that's another way to get an assessment if you are not having a difficult time seeing that plantar flexion movement. Next, we have the Feist line. So I have a pen here, and then I have a small goniometer here. So the way this is going to work is we're going to first do a little bit of drawing. So we're going to do a mark at the base of the medial malleolus. And then, I don't know if you can see that. I can see that. So then we're going to do another mark on the tuberosity of the navicular. And then we're going to do another mark here at the base of the first metatarsal. For some reason, I like dots today. Some people draw lines. And then you're going to take your goniometer and measure that angle while they're in supine. So Katie right now is at 12 degrees. And then I'm going to have her stand. While she's standing, I'm going to move the camera. So then from here, that'll do. From here, we're going to put her in subtalar neutral. So we're going to palpate the domes on either side. And then get her to pronate until they're equal. And then can you hold that? So she's going to try and hold that position the best she can. And then we're going to get that measurement again. So now she's at 20. And then from here, we're going to have her relax and go to where she normally is. I'm actually going to get a little lower. And then we're going to measure that angle again. So now she's at 22. So having a bit of a drop is normal and is very common in most people based on the severity of the drop. You can use this as a way to assess over time how their pronation is and if it's getting better or worse. So since we already have these marks on her foot, we're going to go ahead and do the navicular drop test. So this is another way to assess the pronation or pes planus in one of your patients. So you're going to take a sheet of paper like this and your pen, and you're going to place the patient in subtalar neutral, same way as before, and then have them hold it the best they can. You're going to take that pen, you're going to mark it, and then you can have them relax to where they normally are, and then mark it again. So this was the original, and this was when she was relaxed. So you can keep these papers around and use it to get a general assessment. You can also measure this with a ruler later, so you have something to put in documentation as far as their level of pronation in their foot. So as mentioned in previous videos, subtalar neutral is very important, and it creates an anatomical baseline as to the ideal of where they should be. So we want to assess where they're normally at versus subtalar neutral. So subtalar neutral, you're going to palpate the domes of the talus and then have them supinate until your fingers are even on both sides. So that would be their subtalar neutral. It's going to be a little bit different in everybody, but it's important to have that baseline for your patient. All right, next we have the interdigital neuroma test, also known as the Morton's neuroma test, and also called the squeeze test. So, as the name suggests, this is specifically targeting patients that have a potential Morton's neuroma. So, you're going to be squeezing the metatarsals together at 3 different points. So, you're going to squeeze proximally, somewhere in the middle of the metatarsals, and then distally. So if they have any pain with any of those, it could be pain, numbness, tingling, typical neurological symptoms. If they have pain with those, the next step would be to do shearing at in between each metatarsal to see if there's any pain specifically with those. And then from there, you can also palpate in between the metatarsals to see if any specifically are pain provoking. That way you know specifically where it's coming from on the foot. So next we have the Tunnell sign, so our patient's in supine, and this is a neurological screen for potential nerve compression or double crush syndrome. So you can either use a reflex hammer or you can just use the pads of your fingers. So you're going to palpate behind the fibular head to target the common fibular nerve, and you're going to do 5 strikes. 1, 2, 4, 5, and then you're asking your patient if they have any nervous symptoms, whether it's pain or numbness, tingling, things like that. Then you're also going to do behind the medial malleolus to target the posterior tib nerve. Same thing, go for 5. And that is the Tunnell sign. So next we have the Tunnell sign, so our patient's in supine, and this is a neurological screen for potential nerve compression or double crush syndrome. So you can either use a reflex hammer or you can just use the pads of your fingers. So you're going to palpate behind the fibular head to target the common fibular nerve, and you're going to do 5 strikes. 1, 2, 4, 5, and then you're asking your patient if they have any nervous symptoms, whether it's pain or numbness, tingling, things like that. Then you're also going to do behind the medial malleolus to target the posterior tib nerve. Same thing, go for 5. And that is the Tunnell sign. Next we have ankle measurements for swelling. So I have a measuring tape here, and we're going to do the figure 8 first. So with the figure 8, you're starting at about the level of the talus, and you're going to start your measuring tape. You're in centimeters, and you're going to take that measuring tape medially and inferiorly. You're going to wrap around just proximal to the navicular, and then proximal to the 5th metatarsal. Then come back superiorly, and then wrap just distally to both of the malleoli, and then wrap back around to where you started. So that's the figure 8. And then from here, once you can get your tape measure back loaded again, then you're going to measure 1 inch superior, 2 inches superior, and 5 inches superior to the to both of the malleoli, and then you're just going to be doing a circle around. So that way, if you have patients with high ankle sprains, you have a method to get a measurement of that that's standardized. So we got 1 inch here. Flip it over so you have it in centimeters again. So we have that measurement at 1 inch. Make sure you document that. Then from here, we're going to go 1 inch north again. So here, try it at 2 inches. record that measurement and how that's different. And then we'll get 5 inches, so another 3 inches north of that to get that measurement. And then you would record all of those within your documentation. Next, we have Holman sign. This is a screening measure for deep vein thrombosis or DVTs. Along with the Holman sign, if this is positive, you should also look into the Wells criteria as well to rule in a DVT. So for this sign, we have our patient in supine. We have a bolster under their the back of their proximal lower leg. So you want to make sure that it's not touching their knees, so that way you're not biasing the test and biasing your results. And for this one, you are providing an overpressure into passive dorsiflexion and looking to see if that causes any pain in the mid-calf that's not a stretch pain. That would be indicative of a DVT, and that's the Holman sign. Last but not least, we have the Ottawa ankle rules. This is a screening list to indicate the need for an x-ray for a potential fracture. So first we have the ability to weight bear right after the injury, and then we have tenderness to palpation of a few different sites. So we have the lateral and medial malleolus, so you want to palpate around and ask if there's any pain with that. Medial. You also want to assess the navicular for tenderness to palpation. And last but not least, the base of the fifth metatarsal there. This is a specific test for ruling in the need for an x-ray for a potential fracture in the lower extremity.